Good afternoon to all. The topic of my presentation is a safety profile of allergen-specific immunotherapy. Allergen-specific immunotherapy has been used for more than 100 years as the desensitizing therapy for allergic diseases and represents the potentially curative and also the specific method of treatment. The mechanism of action of allergen-specific immunotherapy or acid include the very early desensitization effects, also modulation of T and B cell response, and related antibody isotypes, and also migration of eosinophils, basophils, and mast cells to tissues, as well as release of their mediators. Regulatory T cells have been identified as key regulators of immunological processes in peripheral tolerance to allergens. I'm not a really big fan of history, but some of these dates I need to mention. The first immunotherapy was administered in 1911 as grass pollen immunotherapy, which was administered by subcutaneous way. All information about immunotherapy during the years were on the basis of empirical information of the doctors, and that concept was overwhelmed by making purified and standardized vaccine extracts. Also, I need to mention year 1986, when was in the use first double-blind trial of SLIT. The using of purified and standardized allergen extracts, and also the good number of the patient who have indication for that was the basis for good clinical knowledge today. And at the year 1998, the European Academy for Allergology and Clinical Immunology was introduced the add-on studies and also promote the concept of clinically relevant allergens in vaccines. This is one picture when we can see a very short version of how acid is really doing. At the first administration of acid, we have the most important doing is on T cell response, and the Treg cells as a key regulators of all other doings. The mast cells and basophils have decreased the granulation direction, and also the decreased number of interleukins 3, 4, and 5. There is a suppressed effect of Th2 cell response, and the Tregs by the interleukins 10 and TGF-beta have influence on B cells, where we can see there is a suppressed number of IgE, and also the increasing of IgG antibodies, especially IgG4 that are blocking antibodies. By directly or indirectly way, we have suppression of mucus and also the effects of endothelial cells. When we decide to administrate acid to the patient, we need to make some consideration for the initiation of immunotherapy. First of all, and probably the most important, is the presence of a diagnosis of IgE-mediated disease with positive skin test and the presence of specific serum IgE. Also, the demonstration of the role of specific sensitization in the symptoms, where the exposure to allergen is associated to appearance of symptoms. Also, the characterization of some other triggering factors that could be involved in the symptoms, the severity and duration of the symptoms, as well as subjective and some objective parameters, and also the respiratory function and the monitoring of it, response of symptoms to pharmacotherapy, and availability of standardized and good quality of vaccines. Good quality of vaccines means that each vaccine should contain a clinically relevant allergen. That means allergen that patient is sensitized to. Also, some ingredients of the vaccines have proteolytic activity, so they should be stored separately, and the effectiveness of acid is based on a good quantity of each allergen, and some recommendation is that the clinically relevant allergens, their concentration in the extract should be between 5 and 20 micrograms. Also, we need to make some consideration about the contraindications. Treatment with beta blockers and other socioeconomic factor, and objective proof of efficacy of acid to the selected allergen. Here are the indications for specific immunotherapy. The first one is doing by a subcutaneous way. Those are the patients with presenting with symptoms induced by exposure to allergens, also exposed to a prolonged season, or presenting with symptoms induced by successive pollen season. Also with patient with allergic rhinitis and lower respiratory disease during the peak exposure to the allergen, patient in whom H1 antihistamines and moderate doses of topical corticosteroids do not control symptoms sufficiently, and also the patient who do not wish to undertake constantly the prolonged pharmacotherapy, and to the patient whom pharmacotherapy causes side effects. High doses of SLIT is indicated with patient with rhinitis, conjunctivitis, asthma, also with patients who are inadequately controlled with conventional pharmacotherapy, and the patient who had systemic reaction during STIT, or a patient who have compliance problems with or refuse immunotherapy by injection. Monitoring of acid is very important, and it includes monitoring of efficiency, safety profile, and monitoring data of importance for acid. Monitoring efficiency includes clinical and laboratory tests. We can see some clinically and laboratory tests. I would just say in vivo and vitro tests, specific and non-specific rhino and bronchoprovocation test, and in vitro blood concentration of specific IgE, IgG, and subclasses of IgG. Safety profile. For safety profile, the most important is evaluation patient before, during, and after administration, and if there are some adverse reaction to drugs, local and systemic. My research was carried out in the diagnostic polyclinic section of the Clinic for Allergology and Immunology of the Clinical Center of Serbia in Belgrade, and we looked at retrospective insights into medical documentation, and all statistic was proceeded in the SPSS software. By research, there was 295 patients. 58% were male. We can see here that the most of the patients with a relevant medical history have cardiovascular disease or some previous episode of anaphylaxis. About patients' allergy history, the most of them have had rhinitis. Also, the one big percentage is 25 is with asthma, and also with atopic dermatitis, and one big percentage is 21 was for the patient with Hymenoptera allergy. So we asked also, is the patient having any active treatment for allergy? The answer was yes, for 77% of them. What about using the medication for allergy? The most of patients used inhaled beta agonists, inhaled corticosteroids, nasal corticosteroids, and nasal antihistamines, and others were in majority. Clinically significant sensitization to pollen was to about 73% of patients, and some of them have positive skin prick tests. Some of them they were taken specific EGE, and to 23% wasn't performed any test. Also for mites, clinically significant, 38.6. For food is lack of information. For epithelia, less than 1% of patient was sensitized. Also for MADS. For Hymenoptera, I told that was 21. And for latex, there was not performed any test. So 77% of all patients were sensitized to pollen. And when we are talking about which pollens they are sensitized to, the most of them have sensitization to weeds, mugwort and ragweed in the majority, and also there is a big percentages of patients who are sensitized to pollen of grass. Has the patient received any acid before? 97% no. Those are our results. 67.5% of patients have very good tolerance. That means that they have no local or no systemic reaction. 22.25 were good. That means that have only local. 10% means only local with one severity or only severity or only systemic reaction, and with poor and very poor we didn't have anyone. So I sell this. So in the conclusion, for acid, its advantage as an immunomodulatory treatment versus conventional pharmacological is that alleviates the clinical picture, prevents of the development for new symptoms and sensitization, and the progression of rhinitis in asthma or the more severe diseases. Thank you.
Thanks, Dr. Mitrović, for the excellent presentation. Any questions, comments from the audience?
I have a question. Okay. Do you have any experience of using immunotherapy in treatment of allergic fungal rhinosinusitis?
With what? I don't hear you.
Allergic fungal rhinosinusitis.
No.
Do you have any experience?
No.